what occurred during that time period was legislation that formally established under the Department of Health leadership a maternal mortality review committee that was charged with annually reviewing and reporting on rates and causes of maternal morbidity and mortality, and recommending improvements for care. Along with that was the fact that our DOH was awarded CDC funding through their Erase program, which provides about $450,000 a year for the next 5 years to support the work of our MMRC. And the fact that this 24-member committee is really going to be very diverse and represent both clinical and non-clinical stakeholders. And this really goes along with both the governor and the first lady's goal of making New Jersey one of the safest places to give birth in the nation. Some of the other things that that legislation also did was establish both a maternal data center and also a maternal care quality collaborative. So the data center, a little bit more focused on morbidity, where the MMRC was is more focused on mortality, and also generating an annual report card on maternity care that can focus on the 49 hospitals that provide labor and delivery services and look at things like surgical rates, complication rates, and things along those lines. And really, along with that, creating a 34-member maternal quality care quality collaborative that really is interested in taking the data that's available both on the morbidity and mortality side and really moving into looking at some of the upstream improvements we can make, and also looking at some of the interventions that would need to be made in the delivery room and in our prenatal care. To start out with, Governor Murphy has really taken a very progressive view in terms of legislation and some of the other things he can do within the office to impact the lives of women. So this includes legislation that has been addressing equal pay and employment discrimination, ordinances that revolve around the ability for providers to get into buildings to do lead line service replacement, so that we can have safer neighborhoods. Legislation that authorizes our Department of Banking and Insurance to establish state-based exchange for individual health insurance to boost the ability of our residents to access health care. Legislation that really gives the right to vote, franchise to vote, to people who are on parole or probation, and getting them back into the ability to vote, and also supporting a number of people who don't have a lot of money to be able to attend community college up to 18 credits a semester and have that paid for, are very important, and a lot of the things that we're focused on to ensure equity in the state of New
Jersey. We're really looking for that implicit bias training, not just for our clinicians, but for non-clinicians as well. We recognize that, implicit bias can start, just at the reception, going all the way through to everyone who would have a touch point in that patient flow through a facility. Also recognizing that, this is laying the groundwork for raising and building awareness, that it in and of itself will not change behaviors, but we're definitely going to be working over the years to come to really think about ways to refresh that, think about ways to actually now move beyond awareness to kind of changing behaviors and assessing and recognizing implicit bias within oneself, and thinking about strategies to actually mitigate, own those things up front, and really think through how to maneuver in a way that is as unbiased as possible.
One of the first things that goes back to the idea of collaboration is the fact that while we've been able to bring doulas and their services through funding, particularly on the insurance side, into this conversation, we've also had a large focus on community healthcare workers in the state of New Jersey, both in terms of funding and training. In particular, one of the things that our division of Family Health Services is proud of is the establishment of a dedicated training center, along using resources from both our department and the Department of Labor and Workforce Development to have both training and apprenticeship programs for community health workers. So we think that that's a very important group that will assist us as we're dealing with some of the factors around the inequities on maternal health. And also the fact that as we're moving forward in establishing our MCQC, that is going to have a diverse representation. So not just in the Department of Health, but also in Human Services, banking, the Department of Children and Families, hospitals and primary care associations, our family planning leagues, Planned Parenthood, the maternal health consortiums, and also people from the community who have an active interest in this and are experiencing the systems that we're trying to change and some of the reform that we're trying to create.
I think that we are in a really good place to continue this good work in the state of New Jersey. Now that we have the support of our administration, we also have funding to support some of the work that we want to do, as well as legislation that really gives us, empowers us to get this work done in the state. We're really looking to bring this data to action. And so it's so important for us to have the different forms of data that Dr. Adinaro spoke of as it relates to maternal morbidity and maternal mortality, to really inform those decisions of the Maternal Care Quality Collaborative, to make sure that, we have definitely the policy initiatives to help make New Jersey the safest place to give birth, as well as programmatically that our programs are situated and through that health equity lens that we spoke about earlier today, to really get these changes in place. The goal is to reduce maternal mortality by 50% in the next 5 years. And I really think that we're poised to do just that.